All right, future nurses, let's get right into it. Today, we're doing a super fast, high-yield visual review of a topic that is all over the NCLEX, bowel elimination. We're going to cut through the fluff and focus on the absolute life-or-death priorities that you have got to know. Okay, let's do this. So to get started, let's frame this whole thing with one big question. What is the single factor that's behind two totally opposite and potentially deadly problems? We're talking severe diarrhea on one end and critical constipation on the other. What's the one thing that connects them both?
The answer? It all comes down to one thing: transit time. This is the master switch, you guys. How fast or how slow waste is moving through the GI tract pretty much dictates everything else. If you can get your head around transit time, you've basically cracked the code on bowel elimination.
Okay, so let's really dig into this core principle. I want you to think of the GI tract, especially the large intestine, as a giant water manager. Yeah, its job is to move waste out, but its other major job is to absorb water. And transit time is what determines how good of a job it can do.
And this is where it gets super clear. Look at the two extremes. On the last, you've got hypermotility. Things are just flying through the system way too fast. The colon has absolutely no time to do its job and reabsorb water. So what happens? It all comes out as watery diarrhea, which puts your patient at a huge risk for dehydration and losing electrolytes. Now flip the coin. On the right, you have hypomotility. Everything is at a standstill. The waste is just sitting there, and the colon just keeps on doing its job, absorbing more and more and more water. The result? You get hard, dry, almost cement-like stool, which leads straight to constipation and maybe even a total blockage.
So what happens when this whole system just breaks? When transit time goes way off the rails and leads to some really critical breakdowns? We're going to look at physical blockages and what happens when some bad bugs decide to take over the gut.
First up, fecal impaction. This is basically the final boss of severe hypomotility. We're not just talking about regular constipation here. This is a solid, hardened mass of stool that is physically stuck. The patient literally cannot pass it. And here it is, folks, the classic NCLEX trap that gets so many people. Your patient has this continuous ooze of liquid stool. Your first thought is probably, oh, diarrhea. But nope, this is a classic textbook sign of an impaction. What's really happening is liquid stool from higher up is desperately trying to sneak around that giant roadblock. So listen up, if you give an anti-diarrheal medication, you could make that obstruction lethally worse.
Now, trying to fix this, that's when things get really scary. When you try to digitally remove that impaction, you can accidentally stimulate the vagus nerve. Think of it like hitting the body's emergency brake. It can cause the patient's heart rate to just plummet dangerously. I mean, we're talking a potential code blue situation, all from what seems like a simple procedure.
Okay, let's switch gears to the bad bugs. Let's talk C. diff. This nasty thing takes over when broad-spectrum antibiotics come in and just nuke all the good, healthy bacteria in the gut. This gives C. diff spores the chance to grow like crazy and cause some really severe infectious diarrhea. And here's the absolute non-negotiable rule you have to burn into your brain. Alcohol-based sanitizer is useless against C. diff spores. It does nothing. You have to physically wash them off with good old soap and water. That's it, period.
So we know the problems. How do we, as nurses, safely step in and clear things out? This next part is all about the procedures we use, like enemas and NG tubes, with a huge focus on doing them safely.
For enemas, your positioning is literally everything. You've got to place the patient on their left side in what we call the Sims position, with their right knee bent up towards their chest. So, why the left side specifically? It's all about anatomy and gravity. This position lets the enema solution flow downhill, following the natural curve of the sigmoid colon. You do it any other way, and it might not work, or you could even risk injury.
But wait, not all enemas are the same, right? You got to know the risks. A tap water enema is hypotonic, which means the body can actually suck up that extra water, and that could lead to fluid overload. So never, ever give them back to back. Then you've got hypertonic solutions. These do the opposite. They pull fluid into the colon. So would you give that to a dehydrated patient? Absolutely not. That brings us to our safest bet, normal saline. It's isotonic, which just means no major fluid shifts happen. It's your go-to.
All right, moving on up to NG tubes. What's the number one rule? The absolute top priority. Airway, airway, airway. You have to be 100% sure that tube is in the stomach and not in the lungs. And the only way to know for sure with an initial placement is an X-ray. It is the gold standard. You never, ever use that tube for anything until you have that confirmation. And if you're working with a Salem sump tube, you have to know about that little blue pigtail. Here's the deal. It's just an air vent. Its only job is to let air into the stomach to keep the tube from sucking up against the stomach wall. So the rules are simple. You never clamp it, you never hook it up to suction, and for goodness sake, you never squirt anything into it.
Okay, now for the biggest change to the system we can see, the ostomy. This is a total rerouting of the GI tract, where a piece of the intestine is brought out to the abdomen. For us nurses, understanding the stoma is everything.
Your first look at a new stoma is all about one thing: blood flow. A healthy stoma should be beefy red or pink. It should be moist. Think healthy, living tissue. But if you walk in and see a stoma that is purple, or even worse, black, and it's dry, that is a 5-alarm fire. That's a surgical emergency. It means that tissue is dead or dying from lack of blood supply. You need to get the provider on the phone immediately. And check this out. Where the ostomy is located completely changes the game. If it's an ileostomy, way up in the small intestine, the output is going to be pure liquid, all the time. Your number one concern? Dehydration. Move down to a transverse colostomy, and the output gets thicker, more paste-like, but get all the way down to the sigmoid colostomy, and you're at the end of the line. The stool is formed, almost like a normal bowel movement. It's a whole different world for the patient.
Protecting the skin around that stoma is so important, and it really just comes down to 3 golden rules. Rule 1. Empty the pouch when it's about a third to half full. Don't wait. The weight of it will literally pull the seal off the skin. Rule 2. Don't change the whole appliance every single day. You'll strip the skin raw. Every 3 to 7 days is the sweet spot. And Rule 3. When you clean the skin, just use warm water. Soap leaves behind a film, and the new pouch won't stick properly. You're just asking for a leak.
All right, let's bring it all home. We're going to do a lightning round of the absolute life-or-death takeaways you need to have locked in for your exam and for when you're on the floor.
Number 1, and this is a big one.
The vagus nerve. Remember, if you are doing any kind of rectal procedure and you see that patient's heart rate start to tank on the monitor, you stop immediately. No questions asked. That's a huge patient safety priority.
And our second critical takeaway: stoma assessment. Beefy red is beautiful. Purple or black is an emergency. It means the tissue is dying. You do not wait. You do not pass go. You notify the provider fast.
And let's end with this, a real-world scenario. You're walking by a C. diff room, and you smell that familiar scent of alcohol sanitizer on your coworkers' hands as they're coming out. You know that doesn't kill C. diff. You know they could be carrying those spores to their next patient. So what do? What is your priority action as a patient advocate? Something to think about. Thanks for joining me.